So welcome. I'm Katie McClure and I have the pleasure of being the chair of British Computer Society Health and Care Scotland. And I am delighted tonight that we've got Chal along to speak, because I've been trying to get him for quite a while. And that's reflected in the numbers who've signed up for the talk tonight. We are recording, and you're welcome to post your questions in the chat and we'll cover them afterwards. But I'm sure Chal's got a really interesting talk for us, and he's the Chief Technical Officer at the Digital Health and Care Institute. Innovation rather than institute, isn't it? And it's person-centred data sharing, catalyst for service transformation. So right up my street as well, and I'm sure it will be for all of you too. The recording will be posted on our website after some time, once I've had time to chop the front and back and keep the good bits in the middle. And just while I've got your attention, I'm also going to say our AGM and the Derek Coyne Memorial Lecture is on the 1st of September. I'll remind you at the end so that you can all come along. And with that, I think got everybody out of the waiting room. I am going to hand over to our speaker tonight, Chal.
Hi there, thanks very much for that, Katie. I'll just quickly share my screen, get some slides up. Hopefully you can see that okay. Is that coming through okay?
Yes, that's it now. That's in slide mode. Thank you.
Great, thanks very much. So mine, as I said before, I'm Chal Chief Technology Officer with DHI. DHI is Scotland's National Innovation Centre for Digital Health and Care. We're hosted by University of Strathclyde in collaboration with Glasgow School of Art. And DHI has been around for a little while, since 2013. I've worked with DHI since its formation, so I was one of the first employees and kind of helped start it up. Been running successfully for the last 12 years. A year ago, we moved out of project mode. We were considered a project, kind of experiment, if you like. Can an innovation centre work? Does it add value? A year ago, we were kind of granted infrastructure status, which moves us from a kind of 3-year project cycle to a 10-year infrastructure cycle. So that's good news for us. It allows us to be a bit more adventurous and take a longer term view as a result of having that kind of cycle. My own personal background, prior to DHI, I worked for the NHS and for Scottish Government in a variety of health and care transformation roles, worked for health boards, ambulance service, public health systems in various places. My own educational background was in whole systems thinking and public health systems design. So I'm not actually a technologist by background. I did computer science way back in the day, but haven't touched it since. I'm a systems thinker and designer, and whole system kind of advocate, facilitator. So today, I'm going to talk to you on the topic of person-centered data sharing. So what we mean by that is Scottish health and care policy is littered with references to being person-centered in the way we deliver health and care services. Often we are in fact organization-centric as a default in the way health and care services are delivered, and our IT systems and our digital systems reinforce that and can make it quite difficult for health and care professionals who are trying to be person-centered to be so, and instead the computer says no and kind of dictates the way a professionally led system needs to work. And not just the IT systems, but the governance that wraps around them, information governance and various other kind of governance methods that again make it quite difficult in some cases to be person-centered. So this program is all about posing the question, what if we made the infrastructure be person-centered? Architecturally and from a software and solution and a data model and architecture point of view, how would that change the way in which we would then be able to design services and deliver them if the underlying infrastructure was built in that way? I'm going to do predominantly slides, depending on how much I meander while I go through the slides. I might have time for a little technical demo at the end of this of some of the systems that I talk about. If I don't, then we can circulate videos, demos of some of that content for people to consume after the event. So first things first, DHI is predominantly a co-design organization. So as I say, we're not predominantly a technology organization. But we're more about systems design and change management and helping services to transform. We've got a team of designers where the Glasgow School of Arts component comes in. We run lots of co-design activities. These are small groups working with citizens and unpaid carers and charities, NHS organizations, local authorities, and various professionals. And we work in these small group projects to help map and understand their current journeys and experiences and identify pain points and opportunities. And then we effectively work with the front line and with citizens to co-create new ways of working. And so the whole idea behind person-centered data sharing came from citizens, which is, why can't I hold my own record? Why can't I use it to share data as I go about my business across multiple agencies and teams? So a project called Back was one of the first times we heard that from people, as people living with multiple sclerosis, describing the pain and friction of not having any power and not having any control and not having any way to join up the story about themselves across all the different agencies, benefits, housing, health, care, social work, etc. On the right-hand side, you'll see some of the first kind of crude meta-analysis we did of our portfolio of co-design projects. Been running for 12 years. We've got quite a lot of work under our belt. And we mapped all the mentions of different personal data items in co-design with the public and with professionals. And what you're seeing on that pie chart is, in the middle is what's called the social determinants of health. So this is the things that make up our health outcomes. So our health outcomes are not just clinical care in blue. They are our behavior in green, our physical environment in pink, and our social and economic environment in orange. So your housing status, job history, and other socioeconomic factors will determine more of your health outcomes than your clinical care will, and your behavior again will determine more of your clinical outcomes and health outcomes than your clinical care alone will. And so we mapped those, and so the outer circle is about 225 different data items that we surfaced through our co-design work: driver's license, housing status, test results, retail habits from a Tesco club card, for example. So these are the sorts of things that came up in the co-design with citizens, and we mapped those and showed the rough quantum of data items and how they related to these different spheres of influence within the social determinants of health model. The reason we do this is just to maybe just provoke people a little bit into thinking about how we innovate with data-driven innovation in health and care. The vast bulk of our investment and attention in how we do data-driven innovation is in that blue segment using clinical records. And almost nothing happens in material terms, funding, I mean, like actual funded projects in the other zones. And at a really fundamental level, if you're talking about digital health and care, in my view, the two main things that are significant for a patient, a citizen, from this agenda are our ability to personalize services driven by data and to create preventative opportunities driven by data. Those are the two things that really matter in digital health and care. And so if you want to personalize and predict, and you could do otherwise, why would you only use 15.6% of the available data about that person to drive that prediction and personalization? Yeah, so these are the kind of foundations of the concept of person-centered data sharing. And so then our challenge became, how would you activate more of that pie chart in our data-driven research in the first instance, and then hopefully later data-driven service delivery. Here's another piece of meta-analysis. This one we published in the Journal of Medical Internet Research. This is an analysis of our first 52 projects over the first kind of 6 years or so of DHI. Each of these co-design projects was, for example, a dermatology app that took pictures of someone's skin condition on their iPad and used early AI capabilities to stratify the risk of whatever image was being captured, and then facilitated referral into dermatology and triage and other things using those AI-assisted tools. So that's a typical DHI project, completely valid and viable thing to do. But if you do one of those for that, one of them for breastfeeding, one of them for frailty, one of them for MS, before long, everyone's made an app for every clinical segment of our lives. And so what this pattern tells us across all these different organizations and people that we worked with is that's great, but in every one of those projects, they were also asking for other things that the projects could not satisfy because that was a project about a dermatology app. And so it couldn't satisfy my need to share my dermatology data with my rheumatologist because that wasn't the scope of the innovation fund or the project. Or the COPD project wouldn't allow me to take my COPD diagnosis from one system and bring it into the benefit system to help support an independent living award or other benefits application. This is the stuff that citizens are looking for. And when we fund innovation in silos based on conditions, you're only ever going to get so far. There's a glass ceiling in the efficacy of service transformation when you do it like that. So these are the requirements that we elicited from people in those projects, and then retrospectively kind of reviewed to find what hadn't been met by the interventions that were designed and delivered each one of those projects. The top line there, you will probably empathize with immediately if you've had any kind of experience of health and care services for yourselves, or a person you're supporting, perhaps. Tell my story once. Every single co-design project we've ever run has involved at least one member of the public saying how frustrating it is to repeat themselves over and over again. That might be to the GP and then the secondary care team, and then to a third sector organization, or it might be the front desk of the hospital, and then the triage team in the hospital, and then the acute medical receiving unit in the hospital, and then the general ward staff in the hospital. Even within one institution, you find yourself doing it over and over again. And so this is a really fundamental requirement, and it's just too complex for people to solve because the funding that we get for projects to change things can't handle that scope. The other requirements here, I'm not going to go into in great detail, but they were all predicated on telling my story once. So if I have that story, could I hold it? Could I share it? Could I use it as the basis for an interaction with a professional that starts with what I need instead of what the process is looking for, if that makes sense? So when I first attend a clinic appointment, the person I'm coming in and seeing could understand a few key things about me or the person I'm supporting and use that to tailor my care more effectively. Or I might not even be going to the right place. We get plenty of stories in our co-design about people who end up with knee surgery, pop out the other end of that with an optimal clinical outcome, only to find they don't have the range of motion in their knee they once had, and they can't garden anymore. And no one asked them what they wanted to do, and therefore it wasn't significant that they couldn't garden anymore as a result of the clinical intervention, because it was designed to take away their pain and give them as much mobility sustainably as possible. You ask that person what they would do at the start, and they would take the pain and keep gardening, and they wouldn't take the clinical intervention. But people don't know enough to make that decision, and clinical teams don't know enough from patients to offer it, if that makes sense. So there's something around using that story from a citizen digitally, and to use it to automate and prompt and drive workflow that can surface those needs early and make sure that we don't create adverse outcomes for people, or indeed, put them through a preoperative assessment process in the first place. If they're effectively not wanting the surgery. And then the last three kind of come as a triplet. I want to understand and access my data. I want to get tailored guidance based on my data. So a story we hear a lot is I, as a pregnant woman, want to go onto NHS Inform and not read 14 different articles that all tell me what I should do, and then at the bottom it says, "Don't do this if you're pregnant." in a sane world, I would say I'm pregnant, and then I would be shown the things that I could do on the site. This is how we're kind of getting used to this as a concept in most other spheres of life. You know, we're constantly being tailored and having our preferences taken into account as we navigate, but we don't do it in health and care yet. I want to do things on my own terms. So I want to take my data from A to B to do something, to unlock a door, unblock the care I need in some way. For example, accessing a benefit. So these are the kind of systemic themes that we, as an innovation center, can distill from all these individual projects. And so we kind of view it as our job to do those systemic things that the vertical innovation funds don't ask for, but someone needs to do them. Just a few lessons learned from some of those processes and some of that time, more organizationally, in the way you might think about a digital health and care intervention. We have spent a lot of time building condition or use case specific products and treating them like an engineering problem that will solve a health system problem, and then implementing them and finding, for a range of reasons, that they don't scale effectively because there's not enough organizational adaptation or change to take advantage of that engineered solution in the way it was intended to be implemented. And so the business case for said solution doesn't add up after your trial or initial evaluation, and it never seems to leave its initial pilot site. And I'm sure many of you will have had that experience. And that app or product will then be superseded by a new generation of technology before the first one was embedded. And so there's a constant churn of apps and products and devices and things like that that are just constantly coming and going through trial and innovation activities, especially in the NHS, but not really creating any traction. And so we have got some do's and don'ts. So we've learned over the years that kind of churn is what I would possibly unkindly call innovation theater. It looks like we're innovating. It's a good show. People win awards. We generate commercial outputs and spin out new companies and other things, but the system doesn't actually change as a result of all that. Other benefits arrive, and maybe there's economic development benefits and export potential for Scotland, etc. And that's all good and fine, but it doesn't actually seem to change the way the system works. And each year we do that, the legacy environment that we operate in gets older and older technically, and more difficult to interoperate with. And so more and more we are trying to help ourselves and partners in health and care organizations, but also an industry focusing on more generic horizontal capabilities and platforms that can support many services, suppliers, technologies, apps, devices. And we need to see those things as modular and cyclical. And we need to create kind of common, resilient, flexible, reusable platforms that are almost like a kind of commons for innovators and other people to plug into, so that they don't have to hold the burden of integrating and connecting all of that stuff to show the premise and promise. And we need to use those common platforms to demonstrate how we would scale up with less effort on behalf of the NHS or other organizations or industry. I put this in here just a pet peeve because people interchange product and platform all the time in their language. Unfortunately, now everyone describes their product as a platform because platform is the new sexy language. And so I always feel compelled to put up some definitions. We view a platform as something that supports both developers or producers and consumers. So I might log into it myself as an end user and get some value out of it. But a company that isn't the company that produces the platform may also use said platform to accelerate, scale, make more cost effective or more effective their solution by using it. I won't belabor this point, but if you're confused about that at all, circulate the slides, and I'm sure you can go and read some material on the difference between the products and the platform. So I would encourage anyone to view with some skepticism the use of the word platform in many contexts. And I'll show you what I mean by a platform in a health and care context shortly. So examples in health and care in recent years that we've kind of worked around on the platform side. Well, I'll start on the product side. On the product side, there are lots of asynchronous clinic products in the market and have been for a little while now. These are two-way messaging and data sharing applications and software platforms that allow a clinician to work with a patient without there being an appointment, effectively. So more message-based, iterative days and weeks of communication iteratively, rather than waiting 2 months for a 10-minute appointment where everything has to happen all at once. So it's moving from synchronous to asynchronous flow. So there's a school of products in that space. Remote monitoring, so blood pressure or diabetes or respiratory, various home monitoring devices and wearables and other things that allow us to get remote telemetry into clinical dashboards, and then referral management. So enhanced triage, the ability to use AI tools to support screening and risk stratification of populations based on their remote monitoring or self-assessment information. And on the platform side, we view a platform more as something that might store said data independently from any of those products. We've done a bunch of work around open EHR clinical data repositories quite recently that might support data exchange integration. So we had a program called the Health Data Exchange, which I'll talk about a little bit more in a minute, or that might offer logic, rules, engines, and other things that other applications can use to support a decision-making process for a clinician, for example, by surfacing a quality assured kind of standards-based algorithm to ingest data and then output some sort of decision prompt into a software application. So effectively, the stuff on the left is your data and logic layer, and the stuff on the right is your user experience, workflow kind of layer. And again, this may be teaching a bunch of you to suck eggs here, but in most health and care contexts, this is not understood, and people just see the app that's in front of them and it's shiny. Oh, well, let's buy this and it'll solve our problems. Not understanding the kind of NTR architecture beneath it. In a national context, we've got a couple of significant programs that we're supporting. The National Digital Front Door program. I'd be surprised if people are coming along to this event and haven't heard of the National Digital Front Door agenda. So it's the idea of a single point where a citizen can come to start their health and care journey. They might, over time, engage in appointment booking, repeat prescriptions, accessing service directories, self-referring, filling in various self-assessments and other things. That would be the idea behind the Digital Front Door. And then the National Care Service, which is obviously having a difficult kind of legislative and organizational kind of birth, but the idea being to create a more scalable infrastructure, both technical and non-technical, for social care, social work, in the same way the NHS has in some of its key systems and organizations. And then finally, another piece of setup work that is of significance, encourage you to go and have a look at it, is in Scotland's digital strategy, we have the new digital identity service that's been launched there. It's been running actually for a couple of years now in initial trials and starting to scale up. And this is called Scot Account. And so this is the new kind of Pan-Scotland national login that's intended for use across all public bodies. And over time, the scope will likely enlarge to third sector and some private entities when they're involved in public service delivery. The reason I draw this out is it's not just a new login, it's a new login or identity service, and what I would term a personal data store for each citizen bound to their identity. which allows them to hold their attributes, their data, verified in a vault that they have full consent control over. They can delete it. They can consent for that data to be used and be bound to their identity as they interact with different public services. And the idea behind that model would be if I was to fill in all my information as part of a application for a disclosure certificate, for example, then I would be offered the opportunity to save what I put into that government portal in my data store. And then the next time I went into a social security interface, for example, I might be able to, at the very least, see my basic contact details and other things available to be pre-populated into that form without repeating myself. So anyone who's used a password manager, Dashlane, keychain, anything like that in kind of modern browsers would be familiar with this sort of thought process, but effectively just doing that, but for government purposes within the right kind of data protection environments. So that's pertinent to some of our work. So moving into what we are doing, we work across 3 horizons. The first is the point-to-point horizon 1. That's what I described before. Here's our dermatology app that connects to a hospital system and sends an image through. And you've got to do some of that because that's where the money is, unfortunately, in a lot of innovation. It's, give us one of these apps. So we do a bunch of that work to keep funded and keep adding value in the short term. Horizon 2 is what we would term the front door, the kind of emerging future state where people are trying to unify that experience. So instead of having 482 apps for every conceivable possible experience that you might have in health and care, maybe now you have a single login, a single consenting process, a single linkage to your KI number to be able to affiliate what you do with your health record, a single ability to do the big high volume transactions like appointment booking and prescriptions and medication lists, lookups and things like that. But you still have a whole variety of single purpose apps that might then connect via that front door. It's still a bit scrappy because there's still going to be lots of different apps for different purposes, but that's just realistic because there will always be lots of different apps for different purposes. But at least this way there's a single identity and a set of data sharing infrastructure that can, to some degree, make that a little bit more streamlined from a user point of view. The difficulty with Horizon 2 is that it is confined to the domain in which the architecture is conceived, which means that the NHS front door will be the NHS front door, the Social Security front door will be their front door. And so we'll go from hundreds of different apps to maybe dozens, if not hundreds of front doors that are more feature rich and can cooperate with a number of applications, but are still nonetheless siloed from a citizen's point of view. And so we do a bunch of work in Horizon 2, but what we're really trying to touch on and push into is Horizon 3, which is the personal integration horizon. So this is your kind of next generation kind of capability. I'm sure plenty of people have heard of the concept of personal health records or personally held records. It's been around for a long, long time. But we're now getting to the point where digital capacity in society, plus the proliferation of smart devices and the Internet of Everything, is making it more and more realistic that this could be a consistent way of sharing data across services. And indeed, in many cases, citizens are already doing this, but using their own private technologies and their own methods rather than with any kind of great strategy or intent from public services. So what we're trying to do is, if we left this alone, it's pretty clear that your Apples and Samsungs and Googles will eventually create ways of handling verified attribute exchange across agencies. They're doing this already in some countries for driver's license and things like that. You've got your Apple Wallet, for example, which you can use for your payment details and your club cards from supermarkets and the like. It's only a matter of time before someone says, why isn't the driver's license in there? And why aren't my GCSEs in there? And why aren't my training certificates as a A&E nurse in there? So I should just be able to turn up to a new A&E and just show them my QR code and they scan it, and now they've got the pertinent proofs that I have the training and credential I need to work in this place. So it's only a matter of time before that happens on the kind of consumer side, and public services are kind of effectively forced to follow the kind of global norm. And I guess we're trying to do a bunch of work in Horizon 3 to help public services be a bit more intentional about that and not be kind of led by the nose by kind of multinational conglomerates who have a wide range of privacy considerations, to put it delicately, ranging from Apple, who are pretty privacy conscious, and actually they have made plenty of decisions that go against their commercial interests in order to maintain privacy and keep data located on your phone rather than in cloud services, all the way through to others who are far less discerning. So anyway, that's the kind of work we're trying to do. So examples. Horizon 2, a health data exchange. So we put this into place 5 years ago. We did this in partnership with NHS Lothian, Grampian, and Great Glasgow and Clyde. And we hosted a data exchange platform. This was made up of two environments. One was a sandbox environment that DHI had control of, and one was a production environment that was hosted inside Microsoft Azure, inside NHS Azure tenancy. And what this exchange allowed us to do was single login, single consenting engine, and the ability for a patient to connect, a wearable device, a Fitbit, smartphone telemetry, home ventilator, that sort of thing, and applications that they might use for proms and prems, so sharing some scores and self-assessments. And then we could connect that health data exchange into Clinical Portal, DocMan, SkyStore, TrackCare, and other IT systems within predominantly secondary care environments for the nature of this project. And then we could build out kind of bespoke clinical dashboards that would connect that health data exchange and use the amalgam of citizen-generated data and clinically generated data to let new things happen, but without it being product-specific. The platform allowed every node connected to it to exchange data via a consent from the citizen using the same identity. And again, that would start to give us the tell my story once potential, because the data would already be there once from, say, someone's wearable data, and they could reuse that multiple times in different interactions, for example. An example of a project that we ran using the Health Data Exchange was called Dynamic Scott. We ran this for 3 or 4 years in Glasgow. This was people with COPD, so acute respiratory illness. They were in and out of hospital repeatedly. They were given a data exchange account. They could use an app to report shortness of breath, fatigue, and various other kind of scores on a regular basis. They could connect their Fitbit and ResMed home ventilator. All that data with their consent came into the exchange. Their clinical records data was pulled, and test results and various other things were pulled out of clinical records. And then some AI engines were developed to parse that data and risk stratify the population. So the first 600 odd people ran this for 2 years, and we demonstrated that we could anticipate risk of readmission to hospital, risk of exacerbation of their COPD, and risk of death. And then based on that, people could then be prioritized for nursing outreach, rescue medications, anticipatory care plans, or whatever other intervention would reduce their risk or prevent escalation in some cases. And that led to a 54% reduction in admissions to hospital and halving the 12-month mortality rate for those people, which is a vastly massive effect compared to what we've seen previously. The reason I put this up is to demonstrate the principle that when citizens and professionals co-produce data, there's data that citizens have at a cadence and tempo that clinicians simply cannot generate because they're not in routine enough contact with you to determine these patterns. And clinicians obviously have verified, trusted clinical markers that are needed to anchor the citizen-generated to distill a pattern and outcome, something of consequence to be said from the citizen's contribution. So there's a partnership here that lets you generate that kind of impact on the system. And so it wasn't the Health Data Exchange that did this, it was the organizational redesign that was possible because the health data exchange enabled that fusion of citizen-generated and clinical data. So that's good, but glass ceiling. Someone could be in this service, we could have half their admission rate, but they could still be living in a damp basement. And they could be exacerbating repeatedly because of the air quality and the generally humid environment they lived in. And they couldn't use any of this in their housing application to get rehomed. And that's the thing that the consultant, respiratory consultant in the hospital says, look, I'm just patching this person up and just helping them survive here until we sort out their housing. Nothing's going to change, and I don't have the power as a clinician to do that. But I've got all this data that proves they have this elevated risk. Wouldn't it be great if that could be used by the person to broker a different outcome from a different agency? Enter Horizon 3. So doing a lot of work around personal data stores. So this is us effectively learning those lessons. And I'm just wary of time. I said 40 minutes max. I'm going to finish up in a minute. The personal data store paradigm is effectively us trying to take that next logical step, which is saying, all right, not NHS focused, not anchored to a front door for one organization. What if your personal data store was completely independent of any of the normal domains? And what if you could port your data flexibly and fluidly between them? Did a whole bunch of work in Midlothian around this and service mapping and several years of engagement with the public and with professionals around what the scenarios would look like if you had that kind of capability. We simulated it using real systems and fake data, and this is one of the simulations that we ran. What you're seeing in that top line is this is a real story: an 88-year-old with dementia and her daughter, who's her unpaid carer. This is 5 months of an 18-month journey they went through as the older adult was getting more and more frail. And what you're seeing there is 19 separate instances over that 5-month period where the person was having to start their story with a new professional from scratch. So, a referral from a GP to British Red Cross, and then a holistic needs assessment, registering for a power of attorney, getting a capacity certificate, getting befriending or link workers set up, getting adult carer support plans in place for the daughter. And so they're repeating themselves over and over again through this process with lots of different agencies, 6 organizations, 11 forms, 875 questions asked and answered. So that's what it feels like to have complex care needs in the health and care system. And this was a good system. This was not a bad system. Midlothian was doing everything right within their capacities, but they were just repeating themselves over and over again, re-administering citizen over and over again from each of these different agencies' perspectives. And that poor mum and daughter just telling their story over and over and over again. So we kind of modeled what would it look like if we mapped all that data and we normalized it and got the British Red Cross holistic needs assessment to capture that about me story once in a reusable format, store it in a personal data store, and then when the person went to each of those subsequent green nodes, that's reflecting them sharing their data once. It was already collected a month ago with Red Cross, and that being the basis for their conversation with that new agency. So I just wanted to leave you with that as a provocation to say, we've done this. We now have put this live in Murray, which is one of our test sites. It's going through evaluation at the moment. So we're trying to determine usability, feasibility, cost efficacy, and cost consequence and efficiencies that might be gained from the organizations involved. But hopefully you'll understand the kind of the potential of this. And yeah, looking forward to questions and happy to discuss.
Thank you, Chal. It was great, real good talk. And it shows the breadth of work that DHI are involved in. And I've always been really convinced by the work you do because you're so forward thinking. You're not looking at now, you're looking 10, 15, 20 years ahead and trying to do the best for the citizens, particularly in your person-centred talk there. No questions come in yet in the chats. You'll just need to be quizzed by me. Which bits get you really excited? What sort of activities?
So I've spent 5 years knocking away AI project proposals because I think for years we have not been ready to do something of significance with AI. I've seen many people just fire the gun way too early.
Yeah.
We've done this ourselves. You get your 3-year funding grant for an AI project, and you spend 2.5 years locating, cleaning, and linking data to make it usable.
Yeah.
And then you get a little bit of AI work done at the very end, and you don't really manage to make the impact you thought you were going to do. I've been through that cycle before. The bit I'm quite excited about now is still small, but we've got 100 or so people up in Murray using personal data stores who have a 700 data item about me story that we've mapped to all those
Wow.
different processes. So we know what the high impact story is. And we've got those people filling that in, and we're starting to give them front door experiences where we can start to tailor recommendations to them about what's in their local community and what might help them based on the story that they hold. And at the moment, we're doing that all through crude decision trees and pretty tried and tested basic sort of logic methods. I personally use a Gemini or ChatGPT or something like that. I'm sure plenty of people in the school are constantly experimenting with new, each generation of the large language models coming through. The one thing that really irks me whenever I'm doing any kind of large language model work is the degree to which you have to educate the model about you to get it to say something unique for
Meaningful.
you.
Yeah.
And we're not quite there yet, but if I tried to get a large language model to interact with my NHS record and therefore personalize something for me, the information governance paradigm would never let me do that as a citizen. If I have my own personal data store, which has that composite story across different agencies, under GDPR, it's my right to take that, and I want to log in to Gemini or whatever it is and say, I give you permission to look at my personal data store. Tell me what I should be interested in doing next. I don't even want to have to think about it. I want to be brought relevant things. Ooh, I see your mum just had a recent health scare, and I see this and that. Can I just check? Are you a bit worried about your own cardiovascular health? Oh, actually, yeah, actually, it has been worrying me a little bit. Well, try this healthy heart tool, just to see how things are going for you. Boom, 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 boom. Would you like me to store the results of that healthy heart tool? Sure. Okay, let's do this again in 3 months' time, and we'll build up a little bit of a profile for you. That's the kind of interaction I'd like to have. Relieve me of the mental strain of that.
Well, Victor has got a question that's really appropriate for what you're talking about just now. So Victor says, I'd like to know, how do you manage security and privacy for all the users and data?
Yeah, so we use a model at the moment. I'm not sure if people are familiar with Midex. So Midex is a community interest company based in Scotland. The personal data store is deployed on Amazon Web Services. Each citizen has their own data store. So it's not a big database. It's individualized to each person. Each person has their identity, login details, and then each citizen has a private key. And it's encrypted, all the data, and so only the private key allows a data sharing agreement to be signed between the data store and someone using the API to retrieve or write data back into the data store. So no interaction can happen without the citizen entering their private key to set up the policy to allow it to happen. So we're trying to operate to the greatest extent possible in a kind of zero knowledge, complete trust environment for the citizen, which is causing us no deal of pain, because you try and get an 88-year-old to understand what a private key is. So as you said, it may not be for this generation, but when my mum, who's been a Facebook user for 18 years, starts to get to this sort of stage, she'll be able to handle the idea of a private key and that she's in control. So these are the kind of protections we put in place to make it super privacy respectful and controlled by the citizen. And then from a security point of view, it's as for any other thing, it's as vulnerable as anything else on AWS that's gone through the necessary, ISO accredited security protocols, I guess enhanced by the fact that the private key entry is needed by the citizen for any new interaction. So there is that extra added component to, if the organization gets hacked, then there's a kind of corroborating piece of proof that's needed from the citizen. So that you have to do pretty well to get access to that person's data through a mixture of social engineering and hacking the PDS provider.
Yeah. Moving on, John has said, have you been able to follow the work that the Belgian hospitals are doing with PODS?
Pods. So these are, I'm assuming, solid pods. Not specifically. I've heard wind of it. It's been quite difficult to get access to some of that. I know also Norway, I think, and somewhere in the Netherlands have also had some personally held record successes, but again, quite difficult with the language barrier to access and understand. I don't see much publicized. So if John has anything he could share, we would very much welcome whatever can be shared, and we'll definitely go and have a look.
Okay, and Stephen says, does this only cover physical health, or do you include mental health? From experience, a big issue now is the lack of communication between the physical health specialists and mental health, yet one can impact the other. Your thoughts on that?
So also Stephen Whitey asking for around pods there under John's piece, and just pods are personal online data stores. So it's just a different phrasing. Just for clarity, there's something called Solid, which is a kind of protocol that Tim Berners-Lee kind of spearheaded, which is around citizens having their own pod that allows them to retain their personal data as they go through interactions on the internet. It's effectively a group of people saying the internet has kind of, unfortunately, created a new techno-feudalist society with large organizations re-centralizing power. That wasn't the way it was meant to be. So we need to reintroduce something that citizen controls to retain parity. And so that's what pods. So if you Google Tim Berners-Lee pods, you'll see a whole bunch of that. Anyway, sorry. So mental health. Yes, there is a section on mental health in the personal data store that we've developed. Handles memory and various communication, anxiety, and other kind of needs. We don't go into kind of very deep end mental health yet, because we haven't had the project work to do so. But certainly the more social and self-management aspects of mental health, we absolutely do include in that. And we've just started a project in Murray around mental health services to try and deepen that. So absolutely.
Yeah. Now Yusuf is asking, he's saying, I don't know much about data in terms of healthcare, but is FHIR, the fast healthcare interoperability resources, used across those systems to enable patient data sharing?
Yeah, so our front door digital portal and the user interfaces and the platforms that sit beneath them that mediate the user experience around how they would store symptoms, how they'd self-assess, and things like that. We use FHIR to store a message around that data. So yes, that said, FHIR is a predominantly healthcare and predominantly medical model. It's growing beyond that, but it's still relatively limited when you take into account our data model for the personal data store includes housing, social security, and a whole range of things that just simply aren't well covered by a healthcare focused model. And so we've got plenty of non-standards based data in that model as well, on the basis that there simply are no standards for a lot of social work, social care, housing, and various other kind of data sets. And so it's a mixture of FHIR, which is very reusable and interoperable, and other things which are a bit more bespoke, because they kind of have to be at this stage.
Yeah. Now, Irvin's asking something I've not heard of. I hope you have. I'm guessing that NHS Scotland EMPI plays a vital role in all of this.
Yes. So the kind of patient index in Scotland would be the CHI number, and there's a kind of CHI lookup system, CHI Community Health Index. The National Digital Platform team holds and runs that at the moment. In our work, we have a unique identifier that is in the personal data store that can be affiliated with any other identifiers. Um, we haven't yet done the work to affiliate it with Chi, because most of the use cases I shared with you in that talk were social, third sector, and other things who don't use the Chi number, don't use a unifying index. But if we were to scale, we absolutely would have to, as you're saying, COSLA, which is the local government representative body in Scotland, has started work to begin using the Chi number that the NHS uses in social work and social care to help unify health, social work, social care using a common identifier. But that work is just starting. So it's going to be a couple of years away at least before we can truly have a kind of patient index number that links to digital identity and is proliferated across Scotland.
Yeah, that's something that NSS has been involved in as well. So, G. Sharman, who has the authority to change the record? That is a person with learning disabilities, doesn't have capacity. It's a number of third sector social care workers. On a visit to secondary care service, a social worker informs of a change of address. Does the third sector social worker have authority to change patient's address?
Yeah. So I don't have all the answers to this, but I can tell you our kind of general approach to it. Most of the answers to that question will be it depends on the trust framework that is set up to govern this kind of technology in whatever use case or locality we're talking about. In our model, I, as a personal data store holder, can delegate access to my personal data store to another person, be it a family member, an advocate, a trusted link worker, or third sector worker, or whoever it may be. And that could be to completely give them read and write access on my behalf and act on my behalf, or it could just be a limited set of permissions for you're reading a little part of my record and doing nothing else. So that's all technically possible, and we have the user interfaces and other things built out to handle that kind of delegated permissioning. The social model around that and the user skill and people understanding what they're doing by setting those policies is a completely different kettle of fish, and that's why this is still innovation and R&D. The technology is ready, but our understanding of what the social and deployment model of that will be is the thing that we're effectively researching at the moment. One of the chief issues will be what happens when someone doesn't have capacity mentally. Are they effectively not getting the benefit of this platform? And the answer at the moment is yes, unless there's power of attorney granted by that person in advance to someone else.
Yeah. And Adam's got another question very much along those lines. Do you see the patient as the data controller of the personal data store?
Yes.
Be really interested in data protection impact assessment covering this.
Yes. So effectively, that's what's happening here. The citizen is signing the data sharing agreements. That's what they're doing when they put their private key in. They are reviewing who is accessing what, and they are determining how and when they want to do it. And we are sharing the data under the basis of GDPR, data access and portability. And in the model I showed, the NHS, the local leisure centre, a local charity, and an unpaid carer, none of these people are sharing data with each other. They're all giving the citizen a copy of the data, and the citizen is in turn deciding to sign data sharing agreements to grant each of them a copy of the data. And that's all automated through the data store infrastructure.
Yeah. One last question from Thomas, and I want to finish up sharp because I know you've got another meeting at 6 o'clock as well, Chal. Thomas says, is it set up so you can choose what specific data is shared with each service on each data sharing agreement?
So at this stage in the R&D phase, we have set up living labs, which are effectively kind of local communities where people can volunteer into the research. We sit down and have community engagement events with them, and we help them get set up and things like that. And in that context, we're saying to them, we don't know enough yet about what fine-grained control is needed for different circumstances. So to sign up to this research, you are consenting for the totality of what you put into your data store to be made available to researchers and to the clinicians and third sector groups that are part of the collaborative. so that we can work with you in code design and co-production to figure out how that data helps you and doesn't, and if there's unintended consequences of sharing that data in that open way within a consented environment. And then what we'll effectively be trying to do is figuring out how to give the citizen fine-grained control when they want it, or how to set up policies. And in my head, I've got this oversimplistic thing. Is there's going to be a slider that says super private but not very effective at one end, and super effective but not very private at the other. And then we're going to say we've put it in the middle to start, and then you can dial either way.
Yes.
So we'll need to create some simplified decision-making tools to help someone meaningfully make those decisions, because frankly 98% of the people you engage with say, I don't care, I just want it to work. Can you give it to anyone and just make it work? And that's not good enough. So we need to try and help them make better decisions. And equally, we need to give the 2% who really want to tick each and every box on and off and say, not that, this, not that, this. The second group is actually quite easy. Giving them that fine-grained control. It's how do you give meaningful consent control to the massive group who just wave their hand and say, just make it work. So
why aren't you doing this already, as they say?
Exactly. So we can technically do that. We have not yet figured out the balance of how to do it and what different policies and things. Yes, Facebook knows everything anyway. Indeed.
So does Tesco.
Indeed.
Fantastic talk. Thank you so much. And thank you to the audience for all the questions. That's been a really busy chat tonight, and really enjoyed that, to see that too. I've popped a link in the chat as well for the next talk, which is our Derek Hoy Memorial Lecture and our AGM. So hope to see people along then. Chal, thank you so much, and hope your next meeting goes as successfully as this one.
Thank you very much, everyone. Talk soon.
Bye, everyone.
Bye-bye.